Chapter 32, Older Adults. So, to begin with, let's talk about frailty. And frailty is a condition of some older adults that involves loss of function, loss of strength, and loss of their physiological reserve. In other words, if you or even your parents probably were deprived of food or water for maybe 24 hours or 48 hours, you might feel pretty weak at the end of that time, but you would probably be okay. But a frail older adult doesn't have that much physiological reserve, so it might be devastating to them. So physiological stresses that somebody who's not frail can take without a problem can be very damaging to the frail individual. And that word at the end, sarcopenia, that is one of the hallmarks of frailty there. And looking at the word and analyzing it, that just means a lack of muscle or a decrease in muscle. And so one of the hallmarks of frailty is that the muscles waste away. And so the person will have an appearance, if you look at their muscles, they're smaller than what they were in the past, and that's part of that loss of physiological reserve. A frail person is also more susceptible to illness and death, and sometimes there will be cognitive impairment going along with it, depression, and almost always there's a decline in mobility and strength and endurance. And a lot of times there are problems with nutrition, decreased physical activity, weakness, fatigue, and they're less adaptable. Older adults in general like routines and they don't like change, and frailty accentuates that. It makes that situation even worse. So then the next thing to learn about is this concept of geriatric syndromes. So these are not specific diseases, but these are common syndromes that do occur with older adults. And then the commonly recognized ones are pressure ulcers, incontinence, falls, confusion, generalized weakness, and lethargy. So as you can see, these are somewhat related, where if you have incontinence and generalized weakness, you're probably going to be immobile and have pressure ulcers. Or if you have a fall, you may fracture your hip and become bedbound, and then become incontinent and develop pressure ulcers. So these things are somewhat related as well. But when you read about geriatrics, you'll hear about geriatric syndromes, and that's also something that we're going to be assessing for with the older adult. You'll be looking for these geriatric syndromes. Some tips when you're evaluating symptoms, like when somebody comes in with a complaint, or whether it's the individual themselves or maybe their child or some other spokesperson, a spouse maybe. Ask about that person's, or try to find out what you can about that person's baseline. Because sometimes you'll see somebody who's confused and incontinent and I don't know, a little bit combative and all this sort of thing, and you will think it it's one thing if that's the way the person always is or has been for a while. It's quite another thing if that's a sudden change from their usual baseline. So try to find out about the person's baseline. And then also, a lot of symptoms will manifest as incontinence, falls, weakness, lethargy, confusion, changes in sleep. These things, these things are kind of, for example, let's say you, as a student nurse, got the flu. Well, you'd probably complain that you felt badly, that your breathing was a little more rapid, you felt congested, your throat was sore, and I don't know, you might have some other complaints. But imagine an older adult that is doing well but is frail, uh, but they're going along according to their baseline, and they get the flu. Well, they may suddenly come in confused, incontinent where they weren't before. They try to get up and then they fall. So you can see that a lot of these symptoms will, and then if they lose their appetite, they don't have that much reserve, so they may get weight loss. Their loss of appetite may lead to some weight loss. So these kind of things that I mentioned, the incontinence, falls, etc., they can be symptoms of a lot of different diseases that you might have. And that makes it difficult to sometimes to get to the bottom of, well, what is the basic, what is actually happening here. Then another problem that we face is that most older adults will have one or more diseases. They'll be taking medications for various things, and sometimes one disease can mask another. Like, we know that, for example, that chest pain can either be from an MI or from maybe a pulmonary embolism or something like that. Well, just in the same way, an older adult that has congestive heart failure may develop a kidney problem or a liver problem. And so you see some swelling and you just say, well, oh, he's not taking care of his congestive heart failure. And you may miss the signs of some new disease like, say, kidney failure or liver failure that's developing until it's gotten a lot worse. And also, a lot of times with this population, they're taking maybe 10 or more different medications, and sometimes a symptom or something that we think is a disease or a new disease, it can be a result of some of the medications we're giving. And there can be several reasons for that. One thing, maybe it's a new medication. Or another thing, maybe it's not, maybe the medication that it's causing the problem is not new, but we added another medication that's interacting with something that the person's already taking. Or maybe their liver function has gotten worse, so so the half-life of the medications we're giving are getting longer, and they're building up toxic levels. Even though we're giving them the same medications we always have at the same doses, well, maybe they're not able to handle that dose anymore. So there's a number of things. So when an older adult complains about a new symptom, think about what medications they're on, and think about, could this possibly be a problem with one of those medications. Some communication tips. older adults generally have a fear of increasing dependency. And so they may be hesitant to reveal things to you for that reason. Like they may see you as somebody that's going to put them in a nursing home, or somebody that's going to tell their kids that they need to go in a nursing home, or somebody that's going to tell their kids to take their car keys away. And so if you ask, particularly when you ask about questions about their abilities to take care of themselves, they may either lie or exaggerate or just not want to tell you things for those reasons. They may also be hesitant to approach nurses and physicians, approach healthcare providers, or go in the hospital because they've seen people go in the hospital and not come out. They've had friends that come in, and it's very real. Once someone comes in the hospital, we basically tie them down, limit their activities, and if they didn't come in frail, a lot of times they'll be frail when they come out. So and then maybe we give them a iatrogenic or hospital acquired, meaning hospital acquired infection to boot with along with that. So we need to determine functional status, but we have to be aware that just asking about can you do this or can you do that is not always going to give us good information. And maybe they were able to do it in their home, but they may not be able to do it. They have their home set up just for their, for their own needs, and the hospital room is going to be a very different environment. So we need to do objective assessments of their functional status as well. On pages 816 to 817, there's two screening tools that are widely used. The CATS activities of daily living includes things like bathing, dressing yourself, maintaining continence. Those are the very basic activities of daily living. Then the Lawton-Brody is instrumental activities of daily living. And that includes higher level things that you don't need for your basic physical care, but that you need to do to live independently in society. And those are things like using the telephone, arranging your transportation, buying groceries, doing your laundry, those kind of things. So look over both of those tools and be familiar with what's included in that. And that is basically that and mobility are basically what we're talking about when we talk about functional status. Another communication problem is, what do you call the older adult? Well, unfortunately, some nurses just call them honey, grandma, all these kind of things that your nursing instructors would cringe if they heard you saying something like that. Well, they'd probably do more than cringe. They'd probably come over and say something to you as well. But yet, when you get out in the field, you'll hear nurses calling older adults this all the time. So don't do that. Find out the way the person expects you to address them. And that could be particularly in like the great generation, which is like World War II people. They're very, very old now, but there's still a few of them around. They do expect to be addressed as Mr. or Mrs. By a younger person. Now, there are exceptions. Some of them have changed. They may have grown up with that being the idea that adults are addressed that way, but some of them may have changed, but some of them still do expect that. Baby boomers probably are going to expect to be addressed by their first name. So, but you can't assume that either. And particularly if the person has had a role, a leadership role in life where they were like a minister or priest or something, and they were used to being addressed as Father Jenkins or something like that. Why, you don't go and say, "Oh, hey Bob, what's up?" You'd want to find out, and hello, Father Jenkins. I'm going to be taking care of you today. Say that. As far as sexuality, well, a lot of younger people resist the idea of older adults even having sex at all. It's quite surprising that I guess it's kind of revenge, because just as your parents, oh, my child couldn't possibly be thinking about sex, and all that, and so then the kids grow up and they get revenge by, my parents are too old for that. They would not think about something like that, so it's kind of, but as in actual fact, older adults engage in sex and think about sex pretty much to the same degree as everyone else. Now, of course, some adults may have physical barriers there, which we'll talk about, to participating in sex, and then there also may be barriers of you're isolated and you don't see anyone, and that makes it kind of hard. But we should be open and non-judgmental, just as we are with younger people. We should be open and non-judgmental with the older adult as well. Many times the older adult feels more liberated because they don't have the pressures of work schedules. They don't have fears of pregnancy, and some of them kind of cut loose. They go off to an assisted living center, or an older adult community, an RV park somewhere, and what happens in the RV park stays at the RV park or something. But there are, of course, some physical changes with aging. In the female, the vaginal walls become less elastic. The fat layer insulating the symphysis pubis also diminishes, and so you may have pain, and the vagina becomes drier. Clitoris may become overly sensitive, so there may be pain involved, and the patient may ask for guidance on how to on ways to deal with the pain or have less pain associated with sex. And so then you'll probably need to do some research and probably have her do some experimentation to see what works for her too, with different lubricants and maybe different positions and that sort of thing. With males, they will probably have slower arousal, or not always, but they'll probably have slower arousal, and then a prolonged plateau between arousal and ejaculation. And that can be very nice for their wife, because maybe the wife's been complaining for a long time that, oh, you just finished too fast before I even get started. So, maybe this is a blessing in disguise for her. Ejaculation can be shorter and less forceful. And then increased refractory time. What is that? Well, just the time between when you ejaculate and when you can become aroused again. So, whereas when you were 20, perhaps that was an hour, When you're 70, perhaps that's 12 hours. It's going to vary. There's going to be a lot of variability depending on individuals. However, sexually transmitted infections are still a concern. When I mentioned that what happens at the RV park stays there, well, not always. Sometimes it ends up in the doctor's office. Next topic, delirium. And delirium is closely related to dementia as far as they can be confused for one another. But delirium is short, it's usually reversible, and dementia is kind of a slower onset, and in most cases it's irreversible. So delirium can be caused by various things. You may have seen a peer of yours on very bad drugs that was delirious. That it could just be a result of toxins or drugs. Also severe illness. Medications, even an adverse reaction to medications, infection, surgery, or withdrawal from alcohol and drugs. And one of the hallmarks is reduced awareness of the environment. The person may be screaming and seeing all kinds of things, but they can't see what's right in front of them sometimes. Or you go in and you try and talk to them and they just ignore you because they're listening to these auditory hallucinations that they're hearing. Now, that doesn't always happen. Some people that are in delirium you can talk to and they will respond to you, but they will have, to one extent or another, they'll have reduced awareness of their environment. And sometimes you can talk them back into being aware of their environment, but then when you leave them alone, they go back into their delirium. They'll have poor thinking skills. They'll have a behavioral change, which goes without saying. A lot of times that's the way people will describe it. They'll bring someone in and say, "Oh, he's just not himself at all. I don't know what's going on." And the patient is in delirium. And there can be emotional disturbances as well. Dementia, on the other hand, that's a decline in mental ability that interferes with your life, and it's usually slower onset and more lasting. There are a number of factors that are related to it. Age, it increases with age, a family history of dementia, some genetic predispositions, any head trauma. Remember, though, football has been implicated that football players that get a lot of small head injuries and maybe some large occasional concussion or something, but they get these micro, and boxers as well, they will get these micro injuries over time, and then by sometimes even middle age they start getting dementia. And so some parents are now choosing to not allow their sons to play football, which other people are saying, "Oh, that research is totally bogus. Oh, it can't possibly be." So, but unfortunately, it does seem to be well founded, and it's certainly something to consider. Personally, I don't think I would let my son play football if I had one. Although sometimes the son has more to say about it than you do, but anyway, other risk factors: vascular disease. such as diabetes. Diabetes is the most notorious one, but any disease that affects the vasculature. Ethnicity, African Americans, Hispanics have more prone to dementia. And then lifestyle, all kinds of lifestyle factors, everything from smoking, alcohol, etc. So dementia is going to, yeah, and you won't necessarily see an effect on each of these right away, but you'll see effects on at least two of these things, and that's part of the definition of dementia. So it can affect memory, communication, your attention span, your reasoning abilities, judgment, or visual perception. And eventually it probably will affect most all of those things. So next topic is incontinence. And we know there are several types of incontinence. Urge incontinence that's the person that has a sudden urge to void, runs to the bathroom but can't get there in time and loses a large amount of urine. Stress incontinence, that's the person that has a sudden increase in abdominal pressure and leaks urine, like when they cough or when they hit a bump on the road while driving, or anything else that increases that abdominal pressure can cause them to leak. But they don't lose all the urine they have, they just kind of lose a little. Now overflow, that's where the bladder fills. There's usually some blockage, whether it be physical blockage, say from a prostate, or functional blockage because the bladder tone is poor. But for some reason that bladder fills up, and then you void some, but you don't actually empty the bladder. It's kind of like it's sort of like if you had a container that holds 1 liter and you add some more, and that whatever extra you added overflows, but that liter is still there. And then you add some more, and then some more overflows, but you never actually empty the bladder. Then functional incontinence, that's the person that maybe that can't get to the bathroom physically because they've got a broken hip, or it takes them 20 minutes to get from the chair to the bathroom, or whatever reason they're functionally unable to get to the bathroom, and so they're incontinent for that reason. So what you should do when you're troubleshooting incontinence is ask the person to keep a voiding diary for several days and try to identify patterns. Do a medication review and see if maybe the medications. Also look for lifestyle things like coffee, alcohol. Rule out constipation, because when a person is constipated, that affects bladder as well. That pressure from the on the abdomen from constipation can affect the bladder as well. Then do a functional assessment, which is going to primarily center on their ability to get up, to manipulate their clothing, that kind of thing. Can they physically get into the bathroom and safely do everything they need to do there? And then finally we might check post-void residuals, and what that is checking is how much urine is left in the bladder after a person voids. There's 2 ways to do that. You can After they void, you can do an in and out catheter and drain and measure how much you get, or you can get a bladder scanner and after they void, do a bladder scan. And in any case, it should be less than 50. Milliliters, that is. Mental status. You may see changes in the ability to concentrate. Compare the person's present state with their baseline. And there are several instruments that you should look at. The slums and this confusion assessment, this CAM, those are listed in Chapter 6. So go back to Chapter 6 and look at those. The short blessed test and the geriatric depression scale are in the Chapter 32. So just look at the questions on those things and be a little bit familiar with those tests. Other things you might ask, do you think that you have more memory problems than most people? Do you believe that your life is empty? These are getting at depression. Even though the memory, that seems like that would be mental status, and it kind of is, but it's mainly getting at depression. Because you're asking them to compare themselves with their peers, and just as if I asked you, do you think you're less intelligent than your peers? Well, that's not really a question about your intelligence, is it? It's more about your self-esteem. And then, have you had to drop many of your interests and activities? Then, asking about falls, you can ask, do you ever have to grab something to keep yourself from falling? And also, do you have to use something to steady yourself while walking? That could either be a side railing or a cane or whatever. And then directly ask about, have you had any falls? And then they'll probably tell you that most people are pretty honest about that unless they think you're about to put them in a nursing home or something. Then ask about lightheadedness, dizziness. Postural hypotension, we'll assess for that, and we'll talk about that when we get to the objective part. But what you might ask that would be suggestive of postural hypotension is this: if they get lightheaded or dizzy when they stand up. And then, do you have any difficulty getting out of bed or out of the chair? And do you have discomfort in the legs with activity? So all these things would be make a person at increased risk of having falls. And also, as you know by now, I hope, hospitals use fall risk tools. There are various ones around, and they have you assess patients every shift for their fall risk. As far as weakness, fatigue, and dyspnea, ask about changes in energy level, and if there are changes, what effect do they have on the person's lifestyle? Do they have any shortness of breath? And if they do, when does it happen? Is it related to some position they take or some activity they're doing? Then do they have any rapid breathing, any sweating, any anorexia? Do they have recurrent cough? And if so, is there blood in it? And weight loss, that would be kind of getting at tuberculosis or maybe lung cancer. Those three things together, recurrent cough, hemoptysis, and weight loss, that would suggest either TB or lung cancer. Did they get a pneumonia vaccine ever, specifically within the last 6 years? And do they get annual flu vaccines? Then as far as nutrition and hydration, we'll want to know about changes in appetite. You could ask for a 24-hour food and fluid record, or a recall if they can give you a recall. But if you were asking them to do it sometimes in the hospital you'll do a food record as a nurse where you'll record everything that they eat and drink for 24 hours, and usually the nutritionist will go over that and evaluate it. There's also the mini nutritional assessment on page 826, so take a look at that. Ask about any problems with teeth or dentures, and do they ever have a feeling of choking or food catching in their throat. And then try to estimate the amount of daily fluid intake. It should be at least, normally it should be at least 1,500 milliliters. Then as far as urinary incontinence, you'd want to ask about any problem, if they have leakage or if they have problems controlling urine flow. And then with males, ask if they have problems starting a urinary stream, if they have problems with frequency, if they have nighttime frequency or dribbling. Males, as an aside, sometimes they'll get into this, they'll get into an idea that they can only avoid standing up, and they're barely able to stand, they can't stand safely, and then they miss the toilet half the time anyway. And you're thinking, oh, it would just be so much easier if I could teach him to use the urinal, or if he could just sit on the commode and urinate that way. But some of them are very, very resistant to doing that. Anyway, you'd also want to know about the duration of the problem and what factors are associated with loss of control. Then as far as bowel elimination, if they've been having any problems with it, whether incontinence, constipation, diarrhea, if they've had changes in bowel habits, if they noticed blood or tarry stools, and if they didn't notice it, why there is such a thing as occult blood, which is hidden blood, and we can test for that. And a lot of people now have done testing on an outpatient basis because that's a fairly common thing to do, so they may have done that recently as an outpatient. Pain assessment. Do they have pain related to some activity? And that kind of suggests that if there's pain is related to activity, they're probably going to do that activity less. And so sometimes people have decreased mobility just from pain. They could potentially do the activity, but due to pain they don't do it. If they're alert, you can use the regular pain scale we always use, the 1 to 10. But if they have some degree of dementia, but not severe, you might want to use a descriptive words scale. And if they're severely, if they can't communicate, then you have to go with physiological indicators of pain, such as look on box 32.5 on page 829. So, objective data collection. Much of the objective data collection is going to be the same exam procedures as you do with younger adults. But there are some things that you're going to focus on a little more. We'll do height and weight and be particularly attentive to weight changes, and especially a loss of weight. An increase of weight probably is going to be a fluid, particularly if they have congestive heart failure or some condition that causes edema. Those weight changes are most likely to be related to fluid balance. Weight losses are concerning, particularly if you think that they're malnourished. Then you will want to review the complete blood count, and then vitamin B12 level, cholesterol, and then albumin and prealbumin are indicators of nutritional status. Then evaluate their hydration status. Older adults are very prone to dehydration, so you want to be on top of that. Look at the color, texture, integrity, and moisture of the skin. Some older adults will have paper-thin skin, particularly if they were COPD patients that got steroids for long-term steroids. They'll have paper-thin skin, and so you just put a dressing on it, and the tape will cause a skin tear. Inspect and palpate hair and scalp. Look at gums, teeth, buccal mucosa. How did the dentures fit? Look at the tongue. Look for any lesions there in the mouth. Observe swallowing and test the gag reflex, just putting that tongue blade on the back portion of the tongue. Don't poke at the actual uvula. Nose color and consistency, test sense of smell and nasal patency. You should be familiar with all those procedures by now. Then palpate the frontal and maxillary sinuses, both for integrity and for pain, for sensitivity. Then you're going to inspect the eyelids, eyelashes, the conjunctiva, cornea, lens, and pupils. Test near and far vision. Ask about vision problems, and particularly night vision, specks or clouds in the visual field. Floaters can be normal, but they can also be pathological. Inspect the external ear, and then take the otoscope. You're going to be looking for wax impactions, because with the older adult the wax is drier and it can more easily become impacted, and sometimes that can be a simple wax impaction is the cause of conductive hearing problem. Perform the whisper test, and then that's just a gross test of hearing function. Remember, you cover the bad ear and test the better ear first. You stand away from the person where they can't see you and read your lips and whisper a 2-syllable word. And then you test the other ear. Look at the shape of the chest, respiratory rate, rhythms, and patterns. And then percuss and auscultate the lungs in the usual way. And take a blood pressure. If the reading is greater than 160/90, you're going to want to refer for possible adjustment of blood pressure medications. Now, orthostatic hypotension. So you test both blood pressure and heart rate, and you take it lying, and then sitting, and then standing. And you give them about a minute to, if they can tolerate standing for a minute, give them a minute or so to equilibrate before you check the pressure. But you're looking for a drop of 20 millimeters systolic or 10 millimeters diastolic, and The ICD definition for orthostatic hypotension says that if you have a drop that great or greater 3 minutes after rising from supine to standing, then that is orthostatic hypotension. Then you want to test activity tolerance. So this is just a poor man's stress test. If you have a stress test, you wouldn't do this. This is just kind of a way of, if you don't have a stress test. You can have them go from sitting to standing, or you can have them flex their fingers rapidly, which doesn't seem like a lot of exercise, but if the person is poorly conditioned, why, that can raise their heart rate. So you would measure the heart rate before and after. If it goes up more than 20 beats, why then that would be a sign that they have poor activity tolerance. And it also should return to the baseline rate within about 2 minutes. So then after that, palpate all of their peripheral pulses for that they're there and for strength, and then you're going to auscultate the carotid, abdominal, and femoral arteries. You should not hear bruits. If you hear bruits, why then you're going to refer those, because that could be an aneurysm or some problem like that. Evaluate arterial and venous sufficiency of the extremities. Raise the extremities above heart level, see if they drain of their blood or if they change in color. You also would want to look for hair loss. That might be a sign of arterial problems. Then inspect and palpate the veins with the client standing. So as you know, that would kind of engorge those veins, and so then you would maybe find varicosities or other problems of that nature that way. Inspect and palpate the precordium. Then auscultate the heart sounds. Inspect and palpate breasts just as you would in a younger woman, but also look at the skin under the breasts, because sometimes that can be an area of irritation, and there may be skin breakdown under the breasts. Then assess the abdomen in the normal way, although the older adult sometimes has a thinner abdominal wall, so you may have an easier time, say, palpating organs than you would in a younger person. Inspect the genitalia, and that's pretty much the same as for younger adults, except in the woman you're going to test for urine leakage by asking her to cough and see if you see any leakage, and also test for vaginal prolapse by asking her to bear down and see if you see any bulging or anything in the vaginal area, which you could see either rectocele or some problem like that. Observe posture and balance while standing, and then do a get up and go test. This is I've seen this more used in research, to tell you the truth, than in the clinical setting, but it can be used in the clinical setting as well. And what you do is you have the person seated on a straight back chair, and then ask them to get up, walk 3 meters, go back the 3 meters, and sit back down, and you time them while they're doing all of that. 10 seconds or less, they're fine. 30 seconds or more is associated with people that have functional problems. So between there is kind of a no man's land where, well, that's not normal, but there's some maybe some functional problem, but maybe not severe enough to really affect the lifestyle. Then inspect the contour of limbs, trunk, and joints. Palpate wrists and hand joints and do the range of motion. Inspect and check range of motion on the hip joint. Inspect and palpate knees, ankles, feet. Inspect muscle bulk and tone. Observe for tremors and involuntary movements, and test sensation as far as pain, temperature, touch, position, and vibration. And that's the end of these videos. Thank you for your attention.